Okay, so we're here today with Alysia Hoover-Thompson, who I'm gonna let her tell you about her title and her role in the community. She works at the High Country
Community Health.
Yeah.
That's about
initials reverse themselves in my brain. So the H and the C got twisted and I knew I was going to say the wrong thing. So I'm going to let you tell us who you are and your role in the community, and then we're going to get started. Talk about some of the questions that I always ask, and then a whole lot more really helpful information too. So Alysia, welcome. Thank you so much for being with us today.
Thank you, everyone. I am going to adjust my volume a little bit here. So I, first and foremost, I'm a licensed psychologist, kind of a winding path to get here, but I have been here in Boone with High Country Community Health for 3 years and 3 months, according to my Paylocity HR system that I checked this morning. My time here is really split between administrative duties. I think when I first came on board, I was about an 80-20 split of 20% administrative work. So I'm the director of the behavioral health program for the organization, and 80% direct clinical service. Here, I'm in a primary care clinic. There is a decent chance that someone will knock on my door at some point during this hour to interrupt us. And that's what we do, being in integrated primary care. And then over the last 3 years and a little bit, as our team has grown, when I came on board, there were, I think, 3 of us in behavioral health, 4 maybe, to now I supervise a team of 12 across the organization. And so I'm much more in a 50-50 split between admin duties, grant writing, project management, and direct clinical services.
Busy days.
Yeah, absolutely.
Yes. So, and we're gonna answer my 3 questions first, and I think in the process we'll talk a little bit about the clinic and what y'all do, and then I'm gonna ask you to share a whole lot more stuff with us. So, one of the things that we talk about on Wednesday Conversation is how y'all see people who are impacted by trauma. So, if you can talk a little bit about that.
Absolutely. So my world looks very different, right? I am a therapist in a medical setting. Hi, Cynthia. I know there are a couple of folks on here who know what we do very well. And so as a therapist, right, it's not like we have a private practice or group practice somewhere where patients come to us having experienced trauma and they present because they want trauma treatment. Right? The path to get to our behaviorists, and that's what we're called as licensed therapists here, often looks really different. So a patient presents to their primary care provider or their pediatrician, we have a pediatric practice, or their dentist, right? We have dental as well. And they're complaining of a lot of somatic things, upset stomach, elevated respiration or elevated blood pressure, but we can't quite pinpoint, excuse me, a medical cause for what's going on. Sometimes there's some vague depression symptoms, vague anxiety symptoms, in addition to the somatic complaints. And so that's where the PCP will often come to get the behaviorist, whomever is available there in the clinic, and say, help, I can't figure this out. And so then we go immediately into the exam room and meet with the patient right then and there. It's not necessarily pre-scheduled visits. We're meeting the patient where they're already at, which is in their PCP's office. And so at that point, we're all trained to ask the questions, right? All of the trauma-related questions to really get a sense of what's going on with this patient and how can we best treat them from a holistic, whole person care perspective, while being very trauma informed in the process, right? And so the typical patient we see are folks with really chronic disease states. Sometimes that's separate from their trauma, and oftentimes it's related, as we know from all the ACEs studies, that it's very strongly correlated with childhood and adolescent trauma and then trauma across the lifespan. So we know that trauma causes some patients to avoid medical treatment, right? And not only avoid, but wait until things are really, really bad before they come through our doors. And so we are seeing folks who are really sick from a physical health perspective, who have a whole host of untreated mental health things going on as well. And so we work in really fantastic team-based care. As a team, we're huddling daily with medical staff, with nursing staff, with the behaviorists on site to make sure we're addressing all of the needs of all of our patients. So we see things like avoidance, we see non-compliance with treatment, right? We're a federally qualified health center, and I'll talk more about what that means later. But because of our status, our federal status, we have 23 measures, quality measures that we have to report on annually to the feds. And those are things like, do we appropriately screen every patient for depression? Do all of our women of childbearing age, however the feds are defining that, have they had mammograms and their annual pap smears, right? Well, as we all know on this call, an individual who's maybe experienced some sexual trauma is probably not going to sign themselves up for pap smear after pap smear every year, right? Or whenever it's clinically indicated. And so those are the things too that the behaviorists can go in, and on the surface, right, to an untrained medical provider, they just see a patient who's non-compliant with their treatment plan, right? Or who's not adhering to clinical guidelines. And so we can go in and say, there's probably more to the story, right? What's the bigger picture, and how can we help this patient feel safe? Number one, to be here, and then safe to get the treatment that's clinically indicated for them.
I think that was one of the things that fascinated me most, although I was so fascinated by so many parts of trauma work, is that all of those people that either some agencies cut off because they didn't show up 3 times, or
right.
you work with them and why don't you just do A, B, and C, or they didn't follow treatment recommendations. And when I started learning about the brain science of trauma and realized how brains engineered in trauma are focused on survival, have trust issues,
absolutely,
are not good at consistent long-term things because they respond to things in the moment. That was so, and me being one, I think you've heard me say I come from a trauma background, and they would prescribe me antibiotics and I wouldn't take the last 6, or right. They would tell me that I needed to do A, B, and C, and I'd be, that would never happen. One time a doctor told me I needed to sit and eat lunch at least 15 minutes a day with nothing else going on. And I did that one day. And on the second day, I said, I don't have time for this. And so all the people that we labeled as non-compliant, uncooperative, unmotivated,
exactly.
like you said, there's a bigger picture. There's something else going on with their brains.
Definitely. And so I'm really proud of the work that we do here at High Country Community Health. We do a full day, 8-hour training of orientation for all new employees. A part of that is being a trauma-informed healthcare facility. So I do that training for every member of our staff. And so that's from folks who sit at the front desk, right? A patient may come in highly agitated, highly anxious, right? All the big feelings, the big emotions that we see as a physiological response oftentimes, or an emotional response to a physiological need or trauma. We're seeing from the front desk to calling into the call center to working up with the nurses and triage, and then ultimately seeing the medical provider, dental provider. And so I'm really proud that our staff knows to at least have that question in the back of their minds. What else is going on? Let me get the behaviorist, right? I've been called out of sessions to go to the waiting room for a patient who's in distress. The call center has called me. I've been in our dental clinics following challenging patients, right? And sometimes that's trauma related and sometimes not. But more often than not, there's absolutely a trauma component. So I love that we do that kind of work here, and that it's always on everyone's radar. It's really important.
And you mentioned that I liked a lot. It's everybody from the front desk to all the way to the medical professionals, but it's like our secretaries at schools or receptionists in other places. They're the people that are going to see them first. And yes, so that first interaction is going to have a lot of influence over the client's or the patient's experience.
Without a doubt, absolutely. If a patient can walk in the front doors and know that this is a safe place and that they can trust us as a team, right? Not just an individual provider, but as a team, looking out for their best interests, then that goes a long way.
Yeah. And then we'll I think we're going to expand on all of these things when you start talking more broadly about who y'all are and what you do. But can you talk about, you've mentioned dental care, medical, counseling. What are some of the programs and services that y'all have that help people build their resilience and build on their strengths?
Absolutely. A ton of programs. So let me back up and talk a little bit more about sort of the organization broadly. We saw our first patient actually over in the health department, January 2nd of 2013 here in Watauga. That was our first medical clinic. And since then, we're located on State Farm Road here in the Boone office with 5, 6 now medical providers, 4 mental health providers, an ever-growing medication-assisted treatment program for opioid dependence. We have a full dental clinic here in Boone at our old location on Doctors Drive. And then, as probably most of you have heard the buzz in the community or saw what's in the paper recently, that we just purchased a new medical clinic, Dr. Placentra's office, Prime Medical. And we will be taking over January. It's not January 1. I always have in my head January 1, but that's a weekend day. I think it's the 3rd is that Monday. And so that's a whole new Boone clinic. So we have our sites here. We provide medical, behavioral health, and dental services in Avery County in our offices in Newland. We have a reverse integration hub, which is a really cool facility, I think is what I'll call it, in Morganton. And so we were approached a number of years ago by a couple of mental health agencies that said, our patients can't access adequate primary care. Can you all join us and bring primary care to our mental health patients? And so we did. And since then, we've also expanded and we have our own on-site behaviorists there as well. We also have a dental clinic in Morganton. And then we have primary care and gynecology in Connolly Springs, also in Burke County, as well as behavioral health. And then in Surrey County, we have a pediatric practice with some grant funding. We are expanding that to adult medicine as well. We have a very large space there. So we have a beautiful pediatric practice with half of our building not even being used. And so we're using some grant funds to add dental and then also adult medicine. And so we have a child therapist there. So all clinics have licensed therapists, at least one. And then also, usually it's a bachelor's level social worker they're called patient resource specialists, but they're kind of the person in the know. I liken them to the person at the front office in schools, right? Like that is the person you go to with any question, and they without a doubt will have the answer. That is our patient resource specialist in each clinic. And so they work with patients on case management needs, whether it's mental, dental, or behavioral health related. They really can connect patients to resources in the community, whether that's medication needs, housing, food boxes, right? Things have really changed for us because of COVID, as I think it has for everyone else. And so we have an amazing team with our core services that serve patients to build resilience. But then also we are really, really committed to meeting the social determinants of health, right? And so we have on-site Spanish language interpreters at every clinic. We have a whole team of interpreters. And so they go where the patients are, where the patients are, where they are needed. We're also a migrant farm worker health clinic. And so that is a federal designation that provides us grant funds to have an entire migrant farm worker health program. And that's a team of folks who are going out into camps, into the fields, doing routine blood pressure and blood sugar checks with individuals in the fields, making sure they're vaccinated, whether it's COVID vaccine or flu vaccine or whatever it is that they need, meeting those health needs of that patient population. We have a really fantastic hepatitis C treatment program. For those of you who are aware of treatment for Hep C, it's insanely expensive, like $90,000 per person.
Wow.
So we are able to provide that for free to patients who qualify. And qualify means you don't have insurance or the money to pay for it, right?
Yeah.
So we do that at our clinics. We do really active, HIV testing or anything else. We have full labs at most clinics as well. We do here in Boone. We partner with LabCorp. And so patients really can come through our doors and get all of their needs met. One other thing, I made a list because I didn't want to forget. We have so much that we offer. Registered dietitian, we have a hypertension nurse here in Boone. And so we can send folks home with blood pressure cuffs to monitor blood pressures that we can then access remotely to make sure that we are meeting those patient needs. Obviously, providing telehealth services, that's a huge need for our patient population, like much of what's going on in the country. And then we also provide transportation. And I think that's pretty huge. Thinking about where we are located geographically in some of our areas, Boone is pretty easy, right? We have really fantastic public transport here, but we don't in all of our other areas. And so if a patient needs to get to our clinic, whether it's a medical appointment, dental appointment, or a behavioral health appointment, or they need to see a specialist that one of our staff members referred them to, and they don't have transportation, we'll provide it for free. And it doesn't matter if it's down the road or if it's across the state, we will make sure that patient gets there. So I think we do a really phenomenal job of meeting the needs of our patient population.
Yeah, that's amazing. Mm-hmm. The therapists, do they primarily do individual therapy?
We only do individual therapy. We group therapy as a federally qualified health center. We cannot get reimbursed for group therapy. It's considered out of scope for what we can practice. I think we could do it for free, but we have options for group therapy in the community. We don't need to duplicate those efforts. Mm-hmm. And so everything we do is individual. And that does look a little different. We have one traditional outpatient therapist here in Boone. Her name is Emily Gray. She's a licensed clinical mental health counselor, EMDR trained, and works with a lot of patients who've experienced trauma. And so how we are different is that to access our behavioral health services, you have to be referred by one of our in-house providers, right? So a patient presents to their primary care provider, PCP brings me in or one of the other short-term behaviorists into the room. And then if we determine that you have a need for longer-term therapy, we can transition to Emily ultimately, or one of our other therapists who do similar things. But most of the work we're doing is pretty brief, a handful of appointments. I was telling before most of you joined the call, I saw 5 patients this morning. A couple of those were traditional kind of 50-minute therapy visits, right? What most of us would think of a therapy visit looking like. The others were really brief check-ins. It was patients who were here seeing their medical providers, maybe someone that I had done a longer-term appointment with, even if it was just once in the past, like a 45-minute session. And then I'm popping back in for 2 minutes, for 10 minutes, for 25 minutes, whatever it takes to meet that patient need in the moment while they're already here seeing their PCP. And so we can reduce cost for patients because we can double dip, right? They can see me, they can see their PCP, and they can see our registered dietitian all in the same day. And then going in to make sure, again, that team-based care is so important to us that a PCP will knock on my door and say, hey, I just did this med adjustment. Can you go check in on this patient and make sure we're on the right track? And we don't have to wait. I don't have to wait as a behaviorist to have a release of information signed, to call the PCP, to make a medication change, right? I literally walk down the hall and say, here's what I'm seeing, what can we do about it? And so patients get that really immediate care from the entire team, which is so important for someone who's experienced trauma, right? Getting them through the door is the hardest step. And so once we have them here, if we can meet all of their needs, we're golden.
Yeah, I think about the amount of time in the families that I've worked with, from me talking to them in my office, them calling to get an appointment with a medical provider that's 4 to 6 weeks from now, Then they go into that office and they say, yeah, you need to see so-and-so. We'll have them call you. A week or two after that visit, then somebody calls them to give them an appointment that's another 4 to 6 weeks out. So we're talking about 3 months have come by and they've not even seen the person that they need to get to see in the first place.
Exactly. And the research shows in support of integrated primary care or integrated any care, right? We see integration in pain clinics and sleep clinics and pediatric offices and OBGYN offices. The research shows that, I don't know, something like 70% of patients who are referred by a medical provider to mental health services never actually make it through the doors, right? And there's a variety of reasons for that. But our patients know, and our medical providers know, that if a patient needs mental health services, they're going to get them that same day. That might be, I pop in the room for 2 minutes, right? I introduce myself so patients have a face to a name. I can offer a really quick intervention, right? I'm not talking about long-term symptoms. I'm not doing a full clinical interview. What is happening today that I can help you fix, give you a quick tool, and then let's schedule a follow-up in a week or two and see how things are going.
Yeah, I love that. That's awesome. I know you'll probably come back around to some more stuff when you're talking about your other things you want to cover. Let's talk about your own wellness, because you're talking about a pace that's fairly intense. 5 people by 12. 5 people by 12, supervising a staff of 12. And you told me before the call you're getting ready to expand. So
sure are. It's exciting.
When I first started asking this question, I only asked the list of what do you do to stay well. Then at some point I realized that for most of us, we may have our little list, but then we often either don't do it or we get way past the point where we needed to. So now I'm also interested in, and how do you know when to do the things on your list?
It's true.
What are the things that you do to stay well, and how do you know when to do them?
That I love the second piece of that question. Generally, I know to do them. So my husband is a therapist also. And so we really don't talk work much together. But when he says, seems like you've had a stressful day, right? That's my internal cue to say, I need to do something for self-care, right? And I do the same with him. And I know that I need to engage in better wellness when I'm experiencing, right? It's a parallel process. When I'm experiencing some of the same things that my patients are talking about experiencing, right? Aches and pains, and I'm not feeling good. I'm not feeling energetic. I'm not sleeping well at night. That is my cue to say, I need to do something different, right? I'm also really bad about, I like to be in control, right? Most of us like to feel in control. And so I'll start doing things like rearranging our pantry, right? Obsessively cleaning the house, because those are things in my life that I can control when so much else in my own world is outside of my control. So that is my tell. And it's not a bad tell, right? Because then at least I have a clean house when it's all said and done.
Labels are all turned forward. Yes.
Right, exactly. So my husband is a fantastic support. We have a 7-year-old daughter who's at Green Valley. And let me share, we just moved to Boone. We've been here since end of December last year. And so I was commuting an hour and a half each way prior to that. And so it took us a while. We built a home here, and gosh, we just love it so much. And so with all of the things that come with building a home, like having an acre of mud when you move in, we've just been doing a lot of fun weekend projects around the house. I use the term fun a little loosely there, maybe, but some of them are fun. I also really love cooking and baking and hiking and taking advantage of all the things that we have in this area. At the beginning of COVID, like many people, I downloaded the Peloton app, which I'm obsessed with. And so I have a spin bike. I'm too cheap to buy the actual Peloton bike, even though I would love to. And so I spin, I do workouts, usually, at least when the weather's nice, and I've not done this enough lately. but I try to scoot outside over my lunch break, even if it's just for 10 minutes, and I take a quick walk. We're within walking distance of the Greenway here. Or I just do a lap around the building to get some fresh air, right? It's amazing what a little bit of sun on our faces do for us, especially when we're wearing masks all day.
Yeah.
And then recently, like every respectable 41-year-old woman, I used my birthday money to buy an Oculus. So if you don't know what that is,
I don't know what that is.
Virtual reality gaming headset. I am by no means a gamer, but I love like old school Nintendo and the Wii. And so my favorite game ever was Resident Evil. I played it pretty obsessively when I was pregnant and haven't really played it since because who has time for that? But it just came out for the Oculus. And so I've spent a couple of hours at least every weekend recently playing that video game, and I'm made fun of by my husband and my daughter a lot, but it's fantastic and I love it. So I recommend that to anyone. It's a really immersive world. It's pretty cool. So those are the things I do.
That is, I think, the first time I've heard of that. And I think it's the first time I've heard a female admit to playing video games. So maybe you're striking a path for the rest of us that we will find some new hobbies.
Do it.
So that is a long list. And as you're talking, it occurs to me that you're really talking about giving attention to all the parts of you, the parts that play,
Absolutely.
the parts that create, the parts that need nature, and trying to find time for all those pieces.
Yes, I'm a huge fan of the wellness wheel. It's something that I was introduced to, probably one of my first weeks in my master's program. So I have a master's in clinical mental health counseling, and then I did a postmaster's doctorate in psychology. And one of my first classes, my professor introduced that to us, and I feel very strongly committed to, if I'm ever going to ask a patient to do something in their own lives that I'm unwilling to do myself, then I'm in the wrong field, right? I really try to live in a way that's congruent with, I want to be congruent as a person, right? And that's something I value. So
well, and for me, the wellness piece was so hard for me that I had to start it by thinking of doing it for the benefit of other people. I couldn't manage to do it for myself. And so it was helpful to me to think of it in terms of you're not your best for them if you're not well yourself. And then it became more about feeling good about the wellness piece of it and how much better I felt. But it took that piece of it for me to really start to do that for me.
Yeah, I think that's true for a lot of us.
We had a chat comment that you are endlessly fascinating. And
thank you.
Really, that's what Wednesday conversations are, just love fest. That's all we do. And that she definitely gets the control stuff as reaction to stress. I do as well. Like if I can't control anything else, then I can wash a plate of clothes or go to the grocery store and have something that I can check off.
Yeah.
I have done.
No doubt.
So thank you for sharing all those things that you do to stay well and some of your triggers that you know you need to do them. And so you've covered all the things I wanted to make sure and covered, and now you have a bunch of other stuff that you want to share with us as well. So I'll let you take that. Take it.
Well, I would just love to talk about a little bit more about our organization and why we do. Yes, and well, a new patient can call the office and get a medical appointment, who can then refer to behavioral health. So why we do what we do and why we spend so much money as a healthcare organization to embed 12 of us, 13, right, including me, into primary care and pediatric settings, right? It's a totally different world for people who've never been introduced to integrated primary care. So let me back up a little bit and talk about what the heck is a federally qualified health center. So that is our federal designation. It's been around for quite some time, but it means that as a health center, we receive federal funding under Section 330 of the Public Health Services Act to provide comprehensive primary care treatment. And that comprehensive treatment is primarily for uninsured and underinsured individuals. And all health centers who exist as FQHCs have to provide or have a contract to provide medical, dental, and behavioral health. because we know that when we can combine all of those services under one roof, or at least under one organization, that we see the best possible outcomes for our patients. So we're a part of a broader group called community health centers. So sometimes those terms are used interchangeably in the literature and, text or people talking. And the other really important thing is that we never turn anyone away. We serve everyone regardless of ability to pay. We offer all services on a sliding fee. So any patient who is at or below 200% of the federal poverty level qualifies for some level of our slide. And that is even for folks who have insurance. And so we know that there are a lot of underinsured individuals who may have an $80 copay to see me as a psychologist, but who has $80 laying around, right? Especially when they just paid a copay to see their primary care provider. And so if that patient is at or below 200% of the federal poverty level, we are going to charge them, and federally, legally we can, the lesser of the two, right? Either their slide fee or their insurance copay. And it doesn't matter if your slide is $25 to see medical and then $10 to see behavioral health, or wherever you fall, and you show up and you don't have a penny that day. That's okay. We're going to see you anyway, because that's our patient population, that we are a safety net organization, right? And so we're not going to turn patients away. We will always see you regardless. And so that's really important to to the work that we do and our mission as an organization. So speaking of, the mission is that we provide quality, patient-centered, culturally appropriate, affordable, and compassionate care that meets the whole person's needs. And I think we really do an amazing job of meeting those community needs. Across the state of North Carolina, and this is a little bit dated, this was 2017 data, but there were 40 FQHCs that existed. And so kind of the way that it works is an FQHC covers a county. And there are a couple of counties that are not yet covered by FQHCs, and we are working on that because, as those of you who know our fearless leader, Alice Salthouse, she will never leave a county unserved. And so patients don't have to live in that county to get services from us, right? We're not like a state-based community mental health agency, but we want to make sure that our location is not a barrier to receiving services. So we try to have broad coverage of service areas. Of those 40 grantee organizations, again, this was 2017, so I know we've added a few clinic sites since then. There were about 260 clinics that made up all of those FQHCs, with just shy of 550,000 patients served across the state. 40% of whom are uninsured. And so North Carolina's just done a super shitty job. I don't care if I can't say that. I'm going to say that anyway, of meeting the needs of the individuals who live here, right? Not expanding Medicaid is a huge disservice to individuals. And so FQHCs can meet that need, but man, if patients had Medicaid, it would make our lives so much easier and patients' lives so much easier, right? Because we can provide all of the basic primary care, behavioral health, and dental services all day long. But what happens when someone needs to see a specialist, right? Bye, Lindsay. And so then we're stuck trying to get those services at a reduced cost for free for patients. And so that's where our case managers come in, and they do a phenomenal job, but it's a huge disservice to patients. And so my hope for the state is that we can get it together and expand Medicaid eventually so that we can make sure healthcare is a right. I firmly believe it's a right for all patients, for all individuals. And so it should not be something that, well, anyway, I'm not going to go into my political beliefs, but it's a right. Healthcare is a right. And so I think we do a really great job, right, of meeting those patient needs.
I have seen studies of Watauga that say whatever percentage of our residents have to choose frequently between rent medical care and food. And
Yep.
so that's kind of along the lines of what you're talking about is how difficult it can be to get adequate medical care. And you mentioned the social determinants of health, wages and
Yep.
quality housing and quality medical care and those kinds of things.
Absolutely. It's a challenge for so many of our patients. And as an organization, we're really committed to, we have no employee of High Country Community Health that doesn't make a living wage. And that's important to our administrators, right? Because as we think about being a trauma-informed healthcare facility, as much as we want to be mindful of the impact of trauma on our patient population, we can't ignore the amount of trauma within our colleagues, right? And the staff that we work alongside every single day. And so making sure that we are creating policies and being mindful of the impact of that trauma has been so important. And it's why I think we really are an organization that people love working at, because we really do a fantastic job. I'm biased, but I think we do a fantastic job of meeting those needs for everybody.
I've heard recently about, it doesn't matter how many healthy choices you make individually, if you work for an organization who re-traumatizes or has a toxic environment, and how critical organizational, being trauma-informed as an organization is to the health of their staff, and who in turn pass that on to the people that they serve. So
yeah, without a doubt. Yeah, we really do a fantastic job. And then we train students here. And so we frequently have graduate students from APP providing additional behavioral health services completely free of charge. We have 2 pediatric, again, I use medical language. I probably should have contextualized that a bit at the beginning, that I am a clinical psychologist trained as a health psychologist. All of my clinical practice has been in federally qualified health centers. And so my language is different, right? I don't say clients, I say patients. I use the medical lingo. But we just do a phenomenal job of meeting patients where they're at. And I think that is so important when we're talking about individuals who've experienced trauma.
I know you're probably not done. Let me go back to that chat comment just for a second, where she says, can a new patient call the office to see a therapist, or they have to go through medical? And so I know one question that has come up for me before when making a referral to y'all is, if the person sitting with me and doesn't identify that they have a medical issue that they need to go for a primary care provider for, what would they say then to get with a medical provider? Do I need a physical?
Yeah, just to establish care.
Okay,
right?
just
and that's it. We want to make sure, because a lot of mental health symptoms overlap with physical health issues, concerns, disorders, right? And so that's the other piece, is being a health psychologist and having this full team of integrated behaviorists, is that when someone presents to me with symptoms of depression, I'm just not talking about and looking at their symptoms of depression at face value, right? When's the last time they had lab work? Do we know their thyroid levels are where they should be? If it's a male patient and he's struggling with low energy levels, right? Low motivation. When's the last time we checked your testosterone? How's your vitamin D? And so those are all the things that, as a not medical provider, I can't order labs, but I can surely walk down the hall and talk to the medical team to say, hey, can we get labs on this patient? Is it an elderly patient who's struggling with what looks like dementia and high levels of anxiety? Well, she or he having urinary problems, right? Could there be a UTI going on that has been missed by a medical team somewhere? And so we can easily rule out all of those physical health concerns that can contribute to mental health symptoms. And so yes, call the clinic and say, ultimately, I have a behavioral health need. I need to get established with the medical team. And then we know you're going to see both of us ultimately when that person walks in the doors walks in our doors that particular day.
Okay, that's helpful. Thank you. So Go. You were talking about the federal health.
Federally qualified health centers. Yes.
I told you, my letters are getting switched today. I've not been getting enough sleep. And I interrupted you to clarify that. So go ahead.
No, it's okay. I mean, pretty much I was done, I think, talking about the role that we serve really across the country. So there's a huge network of us. And we all provide really similar services with some nuanced differences based on where we're located. And so oftentimes you'll find us in more rural communities. Prior to coming here to Boone, I worked in some incredibly rural communities in the far southwestern region of Virginia, coal fields of Virginia. And so I was the only psychologist in a 3-county radius. In one clinic, it was had a population of about 400 individuals in that community. We were about 10 miles from the Kentucky border, and the closest McDonald's was 30 minutes away. And so working with individuals, and actually, so how trauma presented in that clinic, a majority of my patients were 40 to 55-year-old men. Right, not the general, especially in super rural communities, the heart of Appalachia, not the general patient population who would sign up to see a psychologist or a therapist, right? But it was a lot of individuals who experienced workplace trauma, right? They worked in coal mines and had a significant physical health injury. They worked in logging or were linemen and had significant injuries. And then suddenly, right, we're in the middle of nowhere, literally, in Appalachia, where culturally seeking mental health services is not acceptable. There's such stigma still. There was stigma even in the medical clinics, right? With front desk staff or with other staff with whom I worked, even to get patients in the door to see me. And so meeting with that patient population as they're going through the disability process. That disability process is, I think, very traumatizing to a lot of individuals. And especially someone who culturally, right, the culture of masculinity combined with the culture of Appalachia and the mountains, if you're not working, what good are you, right? You're not providing for your family.
Right.
And so that really changed my perspectives, I think, of what trauma can look like. And that's not even talking about, it seems like most patients who walked through the doors had some level of pretty significant intergenerational trauma, right? Because we know the research shows that people of Appalachia, for example, higher rates of poverty, higher rates of substance misuse, higher rates of domestic violence and intergenerational trauma. And they're less likely to seek services for any of those things. And so that is why, as organizations, we are so committed to bringing licensed mental health providers into the primary care clinics, because people are willing to talk to the preachers and their doctors, right? And so if we can kind of piggyback on the relationship that those patients have with their medical providers, then we can get a foot in the door. And maybe not do long-term trauma therapy, but I firmly believe, I'm a brief solution-focused therapist. I don't believe that everyone needs long-term trauma therapy, right? It's absolutely warranted for some individuals, but sometimes people just need to be heard, right? Or people need to understand that what they experienced wasn't their fault, and they need someone to verbalize that to them. People need a safe space. And so if I can be that person, or someone on our team can be that person, then I think we've done our job in meeting the needs of patients who've experienced trauma.
Yeah, that's good. I think you saw the question, and I had not actually heard of health psychology. So what led you to that field?
Yeah, it's a great question. Going way back, I never planned to be a psychologist. I was a physics major, went to a small women's college, physics major, thought I'd go to medical school. And I got a B- in my biology class my first year, right? I was one of those college students that I was smart. I did really well in high school. I didn't really know how to study because I never had to. And then I went to a private women's college where everybody was smart. And so I remember my advisor, for better or worse, said, "You're not getting into medical school with a B- in biology." And so I cried and I cried some more. And then I totally changed my plans. And I love physics. I thought I would end up actually as a structural engineer. That was my plan. And so fast forward, I did summer between my junior and senior year of college. I went to the University of Houston and did a research internship on boron compounds, and I hated it, right? I sat in a lab with millions of dollars worth of equipment that I broke weekly by myself, and it was terrible. And so I went back home. I grew up in Northern Virginia. I went back home and I told my parents, first generation college student. My parents were supportive, but I remember my mom said, "I don't care what you do with your life, but we're paying private school tuition. So you're going to graduate with your physics degree next year, and then you can do anything you want," right? And so I ended up taking this winding path of, I did some recruiting. I was in IT and a scientific recruiter. I did lots of like high-end recruiting for Fortune 500 companies and biotech and pharmaceutical companies. The IT stuff was with like JP Morgan and Chase when they merged in the early 2000s. And that sort of led me to this passion of working one-on-one with people. And then I did boarding school admissions for a couple of years. And then I applied to a counseling program, and I ended up at Radford and did my master's. And then it was at some point in my psychology, my doctoral program, that someone from the VA, right? The VA has done integrated care for a long time. And I didn't even know it was an option, that this type of position existed in the world. And so they came to a health psychology class that I was taking, and I heard them give their 1-hour presentation, and I said, "Done, I'm done. This is what I will do for the rest of my life." And so the next practicum I did was at a free clinic. Internships in psychology are like medical school residencies. There's like a national application process. You go somewhere for an entire year. It's a paid full-time job. And so I did my internship and then my postdoc training in integrated primary care. And I've just been here ever since. So I love psychology as a field, right? But I could never be an outpatient therapist who doesn't get to work alongside a medical team. It's just not a fit for me in the way that I see my patients and conceptualize their cases and what I enjoy doing. It's fast-paced and crazy here, and that's exactly what I like. So it's a good fit.
Yeah, very cool. There may have been 2 things that you wanted to make sure you cover. Did you get to do both of your things? Is there anything else you want to add?
No, I don't think so. I mean, I guess the only other thing was just why the heck we bring so many other, right, behaviorists into primary care. And so just a few highlights of that. We know that, gosh, last year, and I have the statistic, 41% of 18 to 29-year-olds met full criteria for anxiety or depression, right, as a direct result of COVID. And so those aren't folks that are necessarily seeking out therapists. Sure, some of them are, but a lot are seeking medication management of symptoms, or they're just showing up in their doctor's office, not quite sure what's wrong with them, right? Because they don't have the classic symptoms. We know that most individuals cycle through the primary care sector each year, while most are not seeing a behaviorist or a therapist somewhere. We also know that most people who die by suicide saw their PCP in the month leading to their death, but only 20% saw a mental health provider. And so we do routine behavioral or routine depression screenings, anxiety screenings, substance use screenings for every patient, every visit. And that's really important to make sure that our patients don't fall through the cracks, right? And so again, meeting the patients where they're at, reducing that stigma, reducing barriers to care is exactly why we're here and exactly why we're growing. So
very fascinating.
That's all I wanted to say, I think.
Well, I love all of that stuff. The connection for those of us who've been doing trauma-informed work between trauma and long-term health impacts. If anybody
Absolutely.
on this call has not seen the Nadine Burke-Harris video, TED Talk, Health Impacts Across the Lifetime, you need to see that. It's powerful. I've seen it over 100 times, and every time I get cold chills in all the same places. So she just does a really beautiful job explaining. One quick housekeeping thing I forgot to say at the beginning, if people don't mind to put their name in the chat so we can keep record of attendance. And then if you have a question for Alysia, you're welcome to ask that. And also if there's something you would like to say to her, I will copy and paste this for her to read later. If you'd like to put something in the chat. And we have a question which was, do y'all use the ACEs questionnaire, the ACEs survey?
We don't. I know, Cynthia, much to your dismay, we do not. Maybe one day you will wear me down and I will pull it out. Now, that's not to say I don't use it. Let me beg. There's a caveat, right, to this answer. What we do use is a primary care-based health questionnaire that looks at social determinants of health, but then also questions related to interpersonal violence and trauma. And so we just don't use the full questionnaire. It's kind of a modified version. And then all of our behaviorists have access to all the questionnaires that they could possibly want and then some. And so that's not to say we won't pull it out and use it as part of a clinical interview, but it's not standard practice for every patient, every visit at this point. Our medical team would maybe kill me if I implemented that.
The only place that I know of in town who does it as routine part of intake is Daymark. Mm-hmm. And I'm sure most people on this call know that the experiences that the ACEs survey asked about is 10 experiences: physical, emotional, sexual abuse, physical, emotional neglect, having a parent who has an addiction, a mental illness, who's been incarcerated, seeing your mother, be physically abused, or divorce. That comes from the 98 ACEs study. But since then, we have found so many. That list has been expanded ×5 to include community violence and bullying and mass shootings and so many other things that we now know to cause trauma. So I was actually with a group on Monday having them do their own ACEs score. And we had a long conversation about, this is really just a conversation starter. You know, it's not by any means comprehensive. And so there's a lot of debate even in our own community about whether to use the ACEs survey or some other form of assessment. So we don't hold it against you that you don't.
Thank you.
So somebody said, thank you for your passion. Your passion for your work is incredible. It's true. I've sat with Alysia in a lot of meetings and you just sit there quietly and listen. And so your energy level on this call I wasn't expecting that. And it's refreshing and it gives me energy as well.
Thanks.
And then thank you for presenting and your story and your enthusiasm, and that we learned new information today. I did too. I always love these calls because no matter how much I think I know about somebody or some place, I always learn a lot of really cool stuff. So definitely putting you even more, y'all are in the front of my mind because so many people I know either don't have insurance, can't afford co-pays, can't get in to see a therapist somewhere else. And case management, what you called, I forget, you had a term for it and said
patient resource specialists.
Kind of like case managers, but we don't have those anymore in this community. When I started this work 28 years ago, we had adult case managers and child case managers, and those were eliminated over time. So the idea that that exists in some form and fashion is really exciting. And so when I have those moms in my office, the one who come through, you know, either multiple times a week or I'm texting with most days, and I'm supposed to be working with the child, and it's very apparent that the parent needs some stuff. It's good to have somebody who can deal with all of that in one place, because getting them to the first store, like you said, can be a feat in itself. So if we can get them there, then y'all could take care of a lot of things all at the same time, which is really great.
Definitely.
So we're going to start to wrap up. You shared some statistics with us. Any other thoughts that you have that you want to speak on before we end things?
No, thank you for the opportunity.
It was great. I learned so much. Thank you. Alysia knows this, nobody else. asked her to do this, I think yesterday.
Yes.
You were just as enthusiastic about yes, I will. So I very much appreciate that. I knew we would learn a lot. I appreciate you taking time out of such a busy day. It was great to be with you. And I will send you any chats that people give you. If the chat, I'll email those to you. And I look forward to seeing you soon.
Perfect. Thank you all.
Thanks for coming. And thanks everybody for being here. We'll see you next Wednesday. And I hope everybody has a good rest of their day.
Thanks.
Thank you.
Bye, everyone.